All right, welcome back. I think we are ready to start. Hopefully everybody got a cup of coffee and is ready to go for the rest of the morning. Um, so it is a absolute honor and privilege as a white guest working and living on Duwamish lands to talk with you a little bit this morning around some updates around Alzheimer's disease and related dementias. I'm honored to be invited back to speak at this wonderful event, which is probably a sign I didn't screw it up too bad the first time. So I'm Chris Rhodes. I'm a neuropsychologist and associate professor here at the University of Washington, located at Harborview, and mostly a clinician, but with some other duties as well. And my hope this morning was to give you a little bit of an update on kind of the context around Alzheimer's disease and other dementias as pertains to our American Indian, Alaska Native populations. To talk about treatment and then to talk a little bit about some programs and services updates. It's a lot of information, but I really wanted to provide these in the slides for your reference. So I'm going to speed through this to make sure that I give my colleagues some time to talk about their fantastic project as well. And you're always welcome to contact me. You'll have a copy of the slides, which has my contact information. I'm more than happy to talk offline about this. So as we know, there are changes that occur as we age, not just in terms of our eyesight and hearing, but also in our thinking abilities. And they happen around age 65 and then again in our 80s. But there's also, and this is true for everyone, but there's also a significant proportion of our population that has more pathological changes. So these are things like Alzheimer's disease, where there's this gradual accumulation of changes in the brain on a microscopic level that affect structure and function. And that yields a very different curve where somebody could have something like Alzheimer's disease that's beginning, but no symptoms, no outward signs. They could have very mild symptoms, or they could have full-blown dementia. So it's useful to think of these things on a continuum and to really disentangle a disease from dementia. And just as a kind of a reminder, the word dementia really just means problems with thinking abilities that interfere with function. So memory problems or language problems that interfere with someone's ability to, pay their bills or remember their medications. So dementia itself really is more of a descriptive term. And Alzheimer's disease is the most common thing that causes dementia, particularly for folks over the age of 65. As we move through kind of the different types of dementia, this is one of those slides with tons of information that we're not going to go through all of it, but these are the most common most common types of dementia. And again, you can see that Alzheimer's disease accounts for between 60 to 80% of all cases. Vascular dementia, Lewy body disease, and frontotemporal dementia. We know a lot more now around which parts of the brain are affected, maybe some of the associated either genetic or neurobiological factors that give rise to this. So again, this is really more for your reference later on. And we also have a greater understanding that this is a huge problem and worldwide, not just here in the United States and certainly not just in Washington. There are close to 50 million people living with dementia at this point, and the vast majority are undiagnosed. So here in the United States, including Washington, fewer than half are diagnosed, so about 45%. And of those people who are diagnosed, about half aren't told they have a diagnosis. So there's a lot of work to be done here. And the majority of cases are occurring in populations that are lower or middle income with fewer resources. So a lot of our work here locally and in the United States and worldwide really needs to be around improving equity and access to an early and accurate diagnosis as well as treatments. So some updated stats here in the United States. We've got about 6.2 million Americans living with Alzheimer's disease. We've got about another 5 million with that early mild symptoms. Half of those folks, it's due to Alzheimer's disease. The other half, it's something else, which again is why an early and accurate diagnosis is important, because some of those things are treatable or reversible. And then for folks over the age of 45, we've got about 15 million with what's called subjective cognitive impairment. This idea that, boy, there's something that's changing or not quite the same, but it's not yet at that level that's detectable or certainly not interfering with function. The numbers in terms of your overall risk after 65 remain about the same. It's about 11%. You can see that that changes as we get older. So from 65 to 74, it's about 5%. And then after the age of 85 or so, it's closer to about 40% of, again, our older adult population will develop, if not Alzheimer's disease, then Alzheimer's dementia. But those numbers obscure some very, very important differences. And there are increasing awareness around disparities. So one significant disparity is 2/3 of all people living with dementia are women. Furthermore, 2/3 of all caregivers are women. So women are disproportionately doubly affected. And there are a host of reasons for that, including maybe some biological factors, but certainly significant differences in early life and later life educational and occupational opportunities and what that means around health behaviors. We also know that there are significant disparities between our Caucasian and BIPOC counterparts. So for older Black Americans, it's about 2 to 1. About 1.5 to 1 for Hispanic and Latinx populations. And we don't know for our AIN or American Indian Alaska Native populations what that number is, but some emerging data from some large healthcare systems, including Kaiser and some of the work that we're doing here, would say it's probably close to 2 to 1. So there are twice as many of our Native counterparts compared to Caucasian folks who are affected by dementia. And one thing that we tend not to address very much is this idea of ethnic loss, that all Native American, American Indian individuals are the same. There's more heterogeneity between tribes than there is between tribes and other groups sometimes. So this idea of really becoming more precise in who we're talking about as we talk about these things, and improving our awareness of the lifespan things that dictate risk, including early childhood opportunities, educational opportunities, healthcare literacy, trust in the medical system and research, and then the systems level barriers that dictate some of these things as well. And this is all nicely outlined in a special report put out by the Alzheimer's Association this year. I encourage you to take a look at it. It's freely available. The link is down there, or the reference is down there. And they spend a little bit more time talking about the problems than they do pointing towards solutions, but it's so important to address these things, and it's past time for organizations to look at things like implicit bias or barriers to care access, and the importance of how we reestablish trust and access to both clinical care and research opportunities, so we have more information around what works for whom. In that report, I highlighted some of the findings as pertain to Native Americans, the term that they use in the report, and almost half perceive race and ethnicity as a barrier to care. The majority have experienced discrimination in healthcare, 9% on a regular basis, 1/3 on an occasional basis. And the things that jumped out as the most frequent were, number one, not feeling listened to. And then, well, I guess number one, the provider acting like you weren't smart, and then not feeling listened to. Also striking was that the majority of the individuals surveyed here thought that dementia and cognitive impairment were just a normal part of aging, which it is certainly not. And then over 1/3 believed they're not going to live long enough to experience dementia. The other thing that struck me here was that our Native American population has the highest percentage of feeling as though it's important for healthcare providers to understand race and ethnicity, and they also have the lowest confidence that that is the case. And I'm going to guess that's born out of experience. So lots of possibilities here in terms of how we can improve this, including building relationships to restoring trust. As somebody who's peripherally involved in research, I'm always amazed at how little we engage in bidirectional learning around what communities actually want and need, and how we can maybe design research studies or clinical interventions to meet those needs versus foisting an agenda on different communities. But certainly it starts with raising awareness and education. And it's, again, it's lovely to see organizations, including the University of Washington and then my home institution here of Harborview, really doubling down on that. So stay tuned. There'll be more updates there too. So here locally, we still have about 120,000 cases of Alzheimer's dementia in Washington. It remains the third leading cause of death. And we have about 300,000 unpaid caregivers. So it's almost 3 to 1 or 2.5 to 1 for every individual with dementia. We've got 2.5 to 3 people who are providing care. And it's a hard job for those of you who are doing it. It's a 24/7. There are no off hours. It's a huge industry, unpaid industry. And it is a huge industry in terms of the toll that it takes on our care providers. So a lot of our work has been around what can we offer as a state and as healthcare systems to help people do that job, knowing that we can't pick up the slack if they can't do it. We also have learned a lot about treatment, and the idea here is until we have something that is a disease-modifying treatment, there still is no cure for Alzheimer's disease. There are no disease-modifying treatments per se, but if we can do things that suppress that accumulation of pathology, we can keep people functioning in lighter stages, earlier stages, and keep people from getting to late stage. And that really is a combination of things, including making sure that we're addressing modifiable risk factors, particularly in midlife, that we are addressing medications, those that have side effects, as well as those that are helpful for memory, keeping people moving physically, mentally, making sure that we're addressing things like diet, dealing with stress, and keeping people engaged in their communities, which is why I was delighted to hear some of the efforts that mentioned by Karatina that are helping elders stay plugged into their communities, and I'm sure that is true in many of our communities around the state. So hopefully I'll give you some ideas about how to do that for folks who have cognitive impairments, which is another level of challenge when you think about technology. There's also been an update in what we know from International Commission around dementia, in that previously it was estimated that about 35% of all dementias are preventable. That number is now up to 40%, which is excellent news. And it really is a lifespan intervention. So if we could improve educational opportunities for kids, that would eliminate 7% of all dementias. If we could address hearing loss in midlife, that would get rid of 8% of all dementias. Things that disproportionately affect our American Indian population and Alaska Native population, traumatic brain injuries, diabetes, other cardiovascular disease. These are all things that treating them in midlife decreases risk for later life cognitive impairment. Same for air pollution in later life. Smoking, depression, I mean, these are things that when you think about brain health and the connection to heart health, they make a ton of sense. So, but this idea of potentially modifiable risk factors, if we can do the right kind of things, accounting for or eliminating 40%, almost half of all dementias, is pretty staggering. So prevention certainly has a role here. And some lovely data that would say if we can do the other things like a healthy diet, getting people to exercise, reducing if not eliminating alcohol intake, stopping smoking, keeping people cognitively engaged, the more of these things you do, the lower the risk of something like Alzheimer's dementia. You might still have the disease, but you might not progress on to the later stages. And all of these things, even if you only do a few of them, may help offset some of that genetic risk that we have a better understanding about too. And part of this, a big chunk of this, is keeping people plugged into their communities. So we have been focusing and working with our partners, our community partners, to not just do support groups and educational events, which are critically important, but also to do work around how do we make our communities more friendly and welcoming to people with dementia, to decrease stigma, keep people engaged. The idea of keeping people plugged into arts and creative engagement events. There are some intergenerational programs, many of these things that translate well to communities all around our state. A couple of pictures from things that have happened here in the Seattle area. including arts engagement. We have a great partnership with the Fry Art Museum, which is a free museum that its mission is to serve older adults and including those with cognitive impairment. Here at our clinic and our center, we have shifted to offering many of the things that we typically offer in person to be virtual, which, again, echoing what you heard earlier, has been great in terms of it improving access for our folks who live on the east side of the mountains or in other parts of the state, or to get family members who live elsewhere able to connect with their loved ones here in a time where in-person things just aren't yet possible, but beginning. So we're doing things like virtual versions of our caregiver forums, caregiver trainings for how to deal with behaviors and other things that occur in dementia sometimes, a virtual garden discovery walk, which is super cool. And we are just now starting to phase in-person programs to be able to offer those. Giving you a little bit of an update with our state plan. This began in earnest back in 2013 and has now moved out of formalizing the state plan into the implementation phase. And we've got multiple projects that are funded, and I believe the budget will be signed off on here shortly, which will fund a couple more things, but I don't want to jinx that, so I won't mention them yet. And in the last 4 years, we have all sorts of things that are available for you and your communities, including safety toolkit, guides for, if you wanted to start an Alzheimer's cafe, how would you do that? You don't need a lot in terms of resources. And again, we're still in the pandemic, so it's not quite prime time for that. We've got a single point of access for all of this information. And the other thing I wanted to tell you about, besides the roadmap here, which is really, I think, probably the showcase or showpiece of the work that we have done, which is a really wonderful guide for all the way from kind of wondering and worried about changes in cognition to mild cognitive impairment, early, mid, and late stage dementia. What are the things that we need to know? What are the resources in our communities here that are there to help us, and what are the national level resources? Recently translated it into Spanish and would love to see it translated into other languages, but that's to be determined. Lots of Dementia Action Collaborative COVID-19 resources. This gets updated every month. You can see down here at the bottom, there are 7 pages of virtual things for, again, that may be helpful. It's a little overwhelming, but there's something in there for everybody, I think. And the last project or a piece from our Dementia Action Collaborative that I wanted to tell you about is our efforts, and I have the privilege of co-leading this, our efforts to improve healthcare for people in their communities around the state of Washington. So this idea of leveraging technology, the exact thing we're doing right now, to help primary care providers learn how to diagnose and treat dementia in their communities. So we have a specialist shortage, and I am consistently amazed at how far people travel to come see us here at Memory and Brain Wellness at Harborview. So that idea of creating local expertise for people to get the care that they deserve in their communities from their trusted providers who know them best, that's our goal with this. So we launched about a year ago. We have sites all around the state. We are continuing to recruit sites. We would love to have involvement from tribal clinics and tribal providers. We have a host of representation here on the west side of the state and some emerging relationships with clinics over on the east side of the state, which is incredibly important. And we have a website if you have providers who might be interested in this. It's a couple times a month. We offer free education credits, and really the value of it, though, is this larger community and teaching providers the things that they need to know and learning from them. We've learned as much in terms of things that people are doing well out in their communities.
Christopher?
Yep. Yep.
We have one question in the chat. So as you mentioned, smoking, is marijuana a cause as well?
For Alzheimer's disease or dementia, that's a good question. And until it's federally legal, we will not have large-scale data that would inform us about that. What I can tell you as a clinician is there are effects that occur as somebody is actively smoking. I mean, your processing speed, short-term memory, not great. There's mixed data in terms of if somebody was a regular smoker, marijuana, and then stopped, probably depending on who you are, how much, other things going on, other substances. There's some data that would say, after about 45 days, those cognitive impairing effects disappear. There's some other data that would say, well, maybe not. So it's, again, until it's federally legal and we can do the kind of studies that you have to do to evaluate that, we don't know. So that's a long answer of we don't know. But it's a good question, especially now that it is legal at the state level. And then I want to leave you with this, that, our goal here is that, after diagnosis, life is not over. And sometimes people avoid getting a diagnosis because they're worried about, oh my gosh, I'm not going to be able to do anything. My life will be over. And we have a lot of work to do around decreasing that stigma and conveying these images of people who live well with dementia in the early stages, and how we can partner to help people do that for years. That is ultimately the goal. So I'm going to stop there. I have included my contact information. Again, you'll have this with the handouts or the slides, and I am always happy. That is my phone number for the phone right behind me here. That's my email address. So always happy to answer questions past today. But maybe I will stop sharing here. And then I'm either happy to turn it over to my colleagues or if there's any other additional questions for the next minute or so.
Awesome, Chris. Thank you so much. Yes, we definitely do have another minute or so. So if anybody else has another comment or question, please feel free to throw that in the Q&A. We'd love to get those answered. I don't see any others coming through, Chris. So at this point, I might just go ahead and we'll start this off with the next presentation. Again, thank you so much for that presentation, Chris. Chandra and Carrie, I will leave it to you now.
Okay, I'm going to go ahead and maybe start. I'm Carrie Lopez from the Portland Area Indian Health Board, and I'm just going to go over kind of the first couple preliminary slides, and then Chandra's going to take over. She's the coordinator for the project. And I first and foremost want to say this has been really great. I have so enjoyed the other speakers this morning, and I'm learning so much. So we're going to talk a little bit about a new project we have at the Northwest Portland Area Indian Health Board. That's the BOLD project. And we've been doing a lot of work trying to collect information of what our tribes are doing. And honestly, it's been relatively impressive. And I just kind of wanted to say I've been at the health board a long time. I'm going on 20 years next year. And I'm a member of the Tolowa Dene Nation, which is Northern California and Southern Oregon. So I think Chandra's struggling a little bit to get our PowerPoint up. It's still in, it's not in presentation.
Let's see here, hold on a second.
Okay. But I'm just going to give a little bit of the history that we have always had an elders committee for our Northwest Portland Area Indian Health Board. We've been in existence since 1972. And when we first talked about applying for this grant, we went to our elders committee and asked for their support. They supported us. We submitted a resolution, and we actually asked them to be our advisory committee on the grant. So our existing elders committee is really active and excited about this grant. So we have already had 3 meetings with them. We're kind of in the process of, remember, this is a CDC funded grant. So right now we are kind of at our 6-month point. We have done all of the CDC requirements. We're working on things like the strategic plan. We are working on things like getting our contract in place for doing some media development. We have met with multiple associations, Alzheimer's Association. Chris talked about the collaborative, so we're really learning a lot. And I do want to say our partners that we've met with and talked to have been so welcoming and so supportive. Go ahead, the next slide, Chan. So the next, our next steps are really, I think, exciting because, like I said, we've done all the CDC requirements and the evaluation plan and our report. So we're really excited to get going on the actual work with our elders and presenting. We have a meeting set up to present our strategic plan and move forward with them. And I really want to stress one of the things about the Indian Health Board, and I've heard a number of the other programs reference us, is we really are there for the tribes. We work for the tribes. The tribes are our bosses, and we take that really serious. Everything we do is supported by resolution and moved forward. Next slide, and then I think I'm gonna. Is there one more, Chandra?
This is mine.
Oh, and the one last thing I am going to say, though, is that we are really anxious to hear from our tribal programs, and we really do want to create some of the gaps that are out there and provide some trainings and work with our tribes about those unmet needs. So I'm excited to be here. I'm excited to hear from the tribes, and thank you so much for having us. We really appreciate it.
All right. Thank you, Carrie. Can you guys hear me?
Yes.
Yes, we can.
Okay, good, because, okay, good. So I'll just move into our next slide. So these are some facts. This is a presentation that we had shared with our board meeting and our elders committee. So we're just kind of using some of the same information here. So this is some of the facts that we shared with our tribal leaders at the health board. And so I can read them. In 2015 to 2017, 1 in 6 American Indian Alaska Native age 15 or older reported subjective cognitive decline, which are self-reported difficulties in thinking or remembering. I can go to the next one with dementia. It's not just the person with cognitive challenges dealing with the condition, but family members and friends too. And then the number of older American Indian Alaska Natives is increasing, and estimated 569,000 American Indians and Alaska Natives are age 65 and older, and this number is expected to triple over the next 3 decades. And then the number of American Indians, Alaska Natives living with dementia is also expected to increase. And between 2014 and 2060, the number of American Indians, Alaska Natives age 65 and older living with dementia is projected to grow over 5 times. So like Carrie mentioned, with some of our projects, the health board has a lot of projects that we've been working on with elders over the years. So from native elder diets to injury prevention around falls, and even projects that are impacting policies that are impacting elders' access to adequate health care and delivery. So next slide. So our project is in progress. Like Carrie mentioned, we're a 3-year capacity building project. We first presented to the health board in July to get a resolution passed, to get the support from our tribal leaders. With that support, once we were funded back in August, then we, September, we reached back out and presented to our tribal elders committee in October. So we meet quarterly with our tribes, and we reported that we were funded and gave them an overview of our plan for the next 3 years in this project. With that, we submitted a really robust work plan for 3 years for this capacity building project, and it has around 8 strategies that we're working on, and 4 of those strategies are found in the roadmap for Indian country, and we'll talk a little bit more about that later on. But right now we've established a tribal advisory committee, and these folks are tribal, serve as our tribal elders committee. So they're probably a delegate or an alternate delegate of one of the Northwest tribes. And they will be the advisory committee that are making the recommendations to us, to our project. And then they'll be guiding the work plan activities that we submitted. And in this work plan, there are around 4 areas that we're really trying to evaluate or our activities and strategies fall under, and those are increasing and mobilizing the capacity of our partners in developing policies to prevent and manage Alzheimer's disease and related dementia, and increase the capacity of education resources and awareness to empower tribal communities and promote early signs of ADR-RD detection through assessment and prevention programs. And then also increasing the capacity of the tribal workforce to support people with dementia. So ensuring that our caregivers and our providers are getting the trainings that they're needing to be able to assist with programs to increase awareness and capacity at the tribal level. We're going to also use the Tribal Advisory Committee to guide us with this work plan, provide input on a needs assessment, provide input to a strategic plan, and then to help us identify key partners and communication strategies. So you can go to the next slide. So here's a little bit about that ADRD funding. So we at the Health Board received the 3-year capacity building cooperative agreement through CDC's Healthy Brain Initiative for building our largest dementia infrastructure. Now it's different from the funding that we have been hearing about recently in the last few weeks around Indian Health Service going to allocate $5 million for ADRD, and that's out there and going to be distributed to 574 tribes. So that's different funding than the funding that Carrie was talking about, and that funds our 3-year capacity project. Next slide. So our year 1 focus is to design a needs assessment or a survey that's going to help us gain information from our target population. And the folks that we're hoping to reach out to are in our tribal communities, our leaders, health program professionals, patient caregivers to elders, and folks that are living with memory loss and ADRD, or that is suffering from some related dementia, and then the healthcare providers and professionals. And then we're going to develop a strategic plan, improving the awareness and education. We want to build community partners through engagement and identify culturally relevant support resources and services. So ensuring that we're using this grant, and we're also ensuring that our Tribal Advisory Committee is able to give us feedback and give us advice on how to implement our program activities from a traditional wellness or tribal cultural way that fits best into the community. So again, that's why we are leaning on our Tribal Advisory Committee to help us with this work. So next slide. So through our community outreach, what I've done recently, back in February, I think I finalized it. I was able to reach out to all of our 43 tribes in Idaho, Oregon, and Washington, and I was able to get a contact for each tribe, either in their social services department, so that might be their social services director, their Title VI programs and their program coordinators, their elder activities coordinator, or their elder meal program. But I do have a contact for all the tribes now. And so now I have access to share information with all the tribes and around the ADRD, around our project, around upcoming trainings and events that are around Alzheimer's disease and related dementia. We also want to recruit tribes for a coalition. That will probably be in year 2 or maybe year 3, but that is something that we are going to be working on, is getting more of our tribes involved in this advisory and helping us with giving us recommendations on how to meet the needs of our tribes. And then we want to recruit tribal elders for public media interviews. So in year 2, likely we'll be able to do some, social media. We're, doing so many virtual meetings and messaging that I know many of our tribal programs and tribal elders they're feeling isolated and not getting the connections to people as they want to be getting. So we're hoping that through this public media messaging and campaigning that we'll be able to reach out, speak with some of our tribal elders, get some interviews going, and then share that with, our Northwest tribes and even nationally around, what tribes are doing or around memory loss, AD and RD. And then one thing I wanted to share is that the Washington tribes, I did learn that of the 29 tribes, at one time, 15 were identified as attending the Savi Caregivers Basic Training for Indian Country that was developed by Dr. Neil Henderson of the Memory Keepers. And this training is to train American Indian Alaska Native caregivers who are caring for our tribal elders with memory loss or some type of thinking problem or cognitive decline, or diseases referred to as dementia. So I'm not sure if those tribes still have the 15 folks that are trained, if there's more. And so that will be part of our assessment when we reach out to the tribes to learn what tribes have heard of this training and have participated in this training, and kind of just see where they're at with providing their caregivers with the proper training that they need that is culturally relevant to our tribal folks. Next slide. So like Carrie said, we've been in the program for about 6 months. We've had many successes and also some challenges or some barriers. Some successes that we've had, we launched the project. So we did this formal letter, we reached out to tribes, we mailed it to tribal leaders, tribal delegates, tribal chairs, health directors, tribal programs to launch our project to just, introduce ourselves. We've reached out and have worked with local, state, and national Alzheimer's associations, agencies that are working with AD/RD, and other agencies that are working with within Indian Country around Alzheimer's disease and related dementia. So some colleges and some universities, some local nonprofits, other tribes nationally. Another success, we established our Tribal Advisory Committee. Again, we've contacted and identified 100% of our NPIHB Tribal Elder Program coordinators. We've identified some existing resources, and then we've identified the tribes trained in caregiving. And then some challenges and barriers that we faced, I think just like, many of us they're related to COVID-19 being the priority. So with that being the priority, it's kind of, overarching, taking people's times away from other programs and putting us into these positions of trying to respond to how COVID has impacted our tribal communities. So what that has also done for us at the health board and many of our tribes and other organizations is having a shelter in place or having us telework. And so we are 100% organization that's teleworking right now, and that's impacted our organization along with having contact with tribes because it's impacted the workforce. Not all tribal communities are opened, and so they're not able to be in the mix of their programs and doing the activities, and we're not able to contact them. And then lack of partners working in AD/RD within Indian Country. There's just like Dr. Rhodes had mentioned earlier, there's just not a lot of data out there or a lot of information out there around how dementia is impacting Indian Country and our tribal folks. So again, access to baseline data, we just don't have a lot of data to start from. And so hopefully with our strategic plan and our community assessment, we're going to be able to gather that information that's going to help us have like a pre and post baseline data, something to work from and something to use to help us increase the knowledge, the education, and even the services that our tribes are getting around AD/RD. And then just not knowing where tribes are with the levels of awareness and education that they have around ADRD. Who are they working with? You know, what is their referral system? How are they detecting? This is all will be all, you know, useful information so that we're able to, you know, collaborate and connect them with partners and other resources that will be useful for the tribes. And then getting a training and caregiver certification that's specific for tribal members. That it's there's some trainings out there that are for caregivers, but they have certain criteria, and many times our tribal members don't fit that criteria. And from a, you know, I was raised by my grandma, and she's 89, and we all come together to take care of her. We wouldn't put her in a home, and I know that's just the way of our Indian people. We take care of our elders, and so we don't have this specific criteria to be certified to take care of our family members. So we want to make sure that if there is a training or a caregiver certification requirement down the road or down the line, we want to make sure that our tribal families and tribal members are able to take care of our people. So next slide. So the Healthy Brain Initiative and the Roadmap for Indian Country, this is the guidelines and what is guiding our work and what is funding us. This is from our funders at CDC. So the roadmap strategies for our project that we are through the Healthy Brain Initiative are to educate and empower community members, collect and use data, and strengthen the workforce. And then our project work plan includes 4 of the roadmap for Indian Country initiatives, and I can share what those are. Let me grab them real quick. So of them, we're using under the educate and empower community, we have encouraged community members to use effective interventions, best practices, and traditional wellness practices to protect brain health, address cognitive impairment, and support persons with dementia and their caregivers. And then promote engagement among tribal leaders in dementia issues by offering information and education on the basis of cognitive health and impairment, the impact of dementia on caregivers and communities, and the role of public health approaches in addressing this priority problem. And then under collect and use data, that strategy, we have one strategy in our work plan, and it's to support collection and use of local data on dementia and caregiving in American Indian, Alaska Native communities to plan programs and approaches. And then the last strategy that we use in the roadmap is strengthen the workforce. And that is to educate healthcare and aging service professionals on the best ways to support families and caregivers of older adults with dementia. So this has been sent out to all of the folks that I've contacted. It was in the letter and just kind of sent out, but it's going to be available on our website shortly, and it's also available on CDC's website. But it's about a 45-page document that kind of just outlines and will guide the work under these specific strategies for this roadmap. And it was also, when it was designed and developed with CDC, it had partners from Indian Country that came along and helped them design this roadmap. And then next slide. And I believe this is our last slide. So Carrie and I are the project staff. And so here's our contact information. If you have any questions or comments, always feel free to contact us. And also, if you have any questions for us now, I invite you to ask us. So thank you. Thank you for your time, and thank you for allowing us to be here to present our new project. We're super excited about it. Both Carrie and I go way back working with our elders committees, and still, you know, being able to care for our mothers and grandmothers and fathers and, you know, uncles. So this program is really personal for both of us. So thank you.
Thank you so much. Oh, I was muted. Thank you so much, guys. That was a great presentation. I'm just waiting to see if any questions or comments come in. Like I said, the previous presentations, the chat is on the right-hand side of your screen for attendees. Please feel free to type in any comments or questions you might have for them while they're still up here. And again, just to mention to everybody, the slides, the recordings and the slides for each of these presentations, they will be available within the next 2 weeks on the ALTSA Tribal Affair website, just as a heads up.
And Amanda, this is Carrie. I just want to also say to the tribal folks out there, especially, we're really excited to focus on some of the prevention stuff that Chris talked about. We have a lot of support for like tobacco cessation programs, for physical activity with our elders programs. So we're really excited to look at bringing in some of those prevention programs and activities and trainings. So I just want to put that out there to our tribes, that we want to, we know how resilient our tribal communities are, so we want to make that a huge part of our focus.
Awesome. Thank you so much, Carrie.